All right. Okay. Hello, everyone. We're going to be talking about allergic bronchopulmonary aspergillosis today, and we'll try to look at some of the evidence behind some of the things that we do. Um, Pretty interesting topic. So these are the topics under which we're going to look at this disease. And then we'll see. So let's talk about Aspergillus. It's an organism that's pretty much everywhere. It's a mold. It's so abundant that wherever you go, there's going to be some exposure to Aspergillus. This can come up in clinic visits when people talk about, oh, I had exposure to mold. There's mold everywhere. It's not something you can really avoid. The spores are pretty small, 2 to 3 microns, which, looking at our airway anatomy, that would go pretty far down the tracheobronchial tree. They remain airborne for quite extended periods, and eventually, if you're lucky, you end up inhaling some. The way it causes problems is that it grows in the airway and germinates and leads to allergic problems, in this case, for the bronchopulmonary aspergillosis. So, Aspergillus itself was first described in 1729, I'm sorry. It was first associated with human disease in the mid-1800s. This was in a woman who was dying of an unspecified lung condition. It's classic for a condition you don't recognize. You call it unspecified. We have 2 of the greats in medicine, Virchow and Osler, who described patients who had what was later thought to be aspergillosis. It seems these gentlemen were pretty much involved in everything to do with medicine at the time. One of them was a young woman who coughed for 11 years, coughed up sputum, which was pretty rich in tissue with aspergillus. And then the allergic component to aspergillosis was first described in 1952. 8 patient case series, almost all of them were asthmatics. And at the time, looking at the paper which they used when they described it, they really didn't know what it was. They just raised a 2-line question. Could it be that this is allergy to aspergillus, and left it at that? And over the years, that kind of developed into something else. I left this slide in. Sometimes it's good to know your enemy. That's the Aspergillus organism itself, with lots of spores. Now think about that. When that detaches, it just kind of like circulates in the air. They're really small, they're really light, they last forever. Aspergillus itself causes a host of diseases in humans, and it's pretty much a very wide spectrum. Based multiple parts of it, you have the person who's completely asymptomatic, doesn't ever develop any disease, and then you have the cavitary lung disease, and then you have patients who are immunocompromised who develop invasive disease, and then you have those who have a large allergic component who previously might have developed things like asthma and other atopic conditions. They tend to develop allergic bronchopulmonary aspergillosis. So it's pretty much there's a predisposing component to developing this disease. And one way to look at it is as a spectrum. As always, not always, as frequently is the case, it's dependent on the host rather than the exposure. Everybody does get exposure, but what happens is what the host looks like. So for those who have a normal immune response, nothing happens. They simply get rid of it and move on with their lives. And for those who have immune compromise, There you have the invasive spectrum of disease. And for those who have a large hypersensitivity component, they have asthma and allergic bronchopulmonary aspergillosis. To go into the epidemiology, it's pretty much a disease of patients who have asthma, and it's been described in the more severe your asthma is, the more likely it is that you do have ABPA. Not necessarily dependent on the other, more like the ABPA makes the asthma worse. And 2 to 14% of patients with cystic fibrosis, not a patient population that we see a lot of. It's also been reported in other non-cystic fibrosis patients, but it's pretty rare. There's no racial or sex predilection, and commonly occurs in the third to fourth decades of life. A lot of the time it gets diagnosed pretty late. The average person who gets diagnosed with ABPA, surprisingly, has had it for about 10 years. That's quite a long time to have suffered with this disease. Now, how does it cause problems? You have the spores, which we just saw. The average person inhales probably about 200 to 300 spores a day. Every day you inhale spores. And this grow in the tracheobronchial tree, leading to the release of chemokines, which might cause decreased mucociliary clearance. There is the natural innate immune response with the macrophages and the neutrophils attempting to clear this infection, but as often is the case, that only leads to dissemination of the cell wall components of the mycelia of the Aspergillus organism. Now that then leads to release of pro-inflammatory cytokines and substances, causing a lot of injury to the airway, and just kind of like a positive feedback mechanism. And eventually there's some hyperreactivity and airway disease. In the normal host, the response is the activation of the Th1 and Th2. The Th1 pretty much functions with the macrophages and neutrophils like we talked about. There's phagocytosis and production of immunoglobulins, humoral response. The Th2 response leads to the allergic component with activation of the IL-2, IL-4 and 5, which leads to activation of eosinophils and persistent release of bronchoconstrictors and vasodilators, which are now manifested as the symptoms of asthma. So it's not necessarily, once again, that the patient has very bad asthma. It's that the patient has asthma that's complicated with allergic bronchopulmonary aspergillosis. This is some kind of a flow chart of what we just talked about. You inhale, it grows, release of proteases, and eventual damage to the airway leading to bronchiectasis and lots of viscous secretions. Similar flow chart, but more just graphics. Now, in terms of the clinical findings, it's not really a single presentation pattern. It could present in multiple ways. For some people, it's just uncontrolled asthma. With a high index of suspicion, you may be able to find it. With some people, when you do the X-rays and CTs for other reasons, you find bronchiectasis, and then you wonder what's going on, and eventually find out that this person has ABPA. The symptoms are symptoms of asthma in addition to occasional fever, airway hyperreactivity, which will come under asthma as well, and cough productive of mucoid sputum. There's a lot of like viscid brown and dark colored sputum. Hemoptysis does occur, but it's relatively rare, and may lead to a diagnosis of tuberculous disease in more TB-prone areas, when you see hemoptysis in a third world country, for example, the first thing that comes to your mind is TB, TB, TB. May not necessarily be the case. The physical exam is often normal or may just mimic a physical exam of an asthmatic patient. For laboratory diagnosis, most important thing is the blood work, which we'll go over in a minute. Skin sensitivity testing is also done, but that's not necessarily very reliable, depending on where you get the allergen from. There's a lot of variation in the response to the allergen, even from different manufacturers, even when you make them in-house, based on the amount of immunogenic material in what this product is. Peripheral eosinophilia may also be present, and is usually present. Now, the radiologic findings for chest X-rays, what you tend to see is a lot of upper and middle lung field disease. You may find some transient infiltrates which may be there very briefly and go away. Mucoid impaction, bronchiectasis, and fibrotic changes in very persistent and uncontrolled disease. CT changes generally show central bronchiectasis, and there's something called the paraspinal muscle sign, which is the presence of high attenuation mucus, which is denser than the paraspinal muscle. It's pretty much pathognomic for ABPA. Once you see it, then there's a very high likelihood that the patient does have ABPA. I've included some of these findings. Finger and glove appearance, which we often see at X-ray conferences. And then that's the high attenuation mucus. If you compare that to the paraspinal muscle, which is the muscle next to the spine, it's more denser. Lots of bronchiectasis in the other image over there. So the diagnostic criteria have pretty much evolved over time. When it was first described, it was just kind of like an afterthought. The first, there's no universal agreement in what to use to diagnose between people in Europe or people in the US or any of the other countries. There's no single best diagnostic test that you can say, oh, I did this test and this man has ABPA. The first set of criteria was proposed in 1977. It was modified a couple of times until it was recently readdressed within the last 4 or 5 years. And the next slide shows the Rosenberg criteria, which looks a little bit busy, and you have to satisfy different conditions in the major criteria and the minor criteria, and kind of mix and match to make the diagnosis. This was recently readdressed and was simplified such that you had about 5 criteria: presence of a predisposing factor, and you have to meet the upper 3, and then possibly the other 2. Treatment goals, to make it simple, there are 2 major avenues to go. First avenue is to decrease inflammation, which we use steroids for. Everything goes away with steroids. The second avenue is to reduce the fungal burden, which makes sense, like Junior talked about a minute ago. There's no point trying to treat the inflammation when the antigenic burden is pretty high and increasing. There is no trial data to support dose of or duration of treatment. Nobody really knows. Studies never got done, and they are probably never going to get done now. For inhaled corticosteroids, they're not really of any use for ABPA, surprisingly. And then for antifungal therapy, itraconazole is the most frequently used medication, just based on the fact that it's chronic therapy, often lasting as long as 6 months, and ketoconazole side effects are much higher. There have been case reports for the use of inhaled amphotericin B and inhaled steroids. So now, just to give some kind of graphic description of the points at which you can intercept this disease condition. The glucocorticoids decrease inflammation and try to block the effects, bronchoconstriction. You can use the antifungals to decrease the antigenic burden, like we talked about. Pretty much, if you kill off all the Aspergillus, then there's nothing left to cause release of antigens. And there have been talks of the use of IgE monoclonal antibodies to reduce inflammation as well. Okay. So just to go over the ATS treatment guidelines, most of the other professional organizations have no formal guidelines for the treatment of ABPA. So the goal of treatment is to prevent and treat acute exacerbations and the prevention of end-stage fibrotic disease. This was often a very prolonged management strategy. This is not the kind of thing that goes away in 2 weeks. You will often have to follow patients for months and years. The systemic steroids are the cornerstone. They're pretty much the only thing that has been well validated for the use of for treatment in ABPA. There are multiple regimens. Initially, you start off with a higher dose and then kind of taper as the patient tolerates and as the disease condition is able to be controlled. For those who either do not meet the criteria for diagnosis or those who have had a good response to treatment, you're going to have to keep following them for months and months. I couldn't find any reference to how long before you say, okay, you're cured now, you may go home. So it seems like it's pretty much there's a lifetime risk of developing this disease once you've had it. You may also start itraconazole, and role of anti-IgE therapy is not currently well established. There have been studies that have been done, but it's not made its way into the guidelines yet. In terms of monitoring, this is kind of like a flow chart that we can use to follow the patients if they're stable. Yes. Sure.
For acute exacerbation, you said then taper to patients pre-exacerbation.
Correct.
And then how long do we continue that?
So there is no definite period, and these are pretty much lifted from the guidelines. There is no definite period to continue the pre-exacerbation dose. But I asked myself that question when I was preparing the slides. What does pre-exacerbation dose mean? If this was a person who came in and you diagnosed him with ABPA and he wasn't on steroids, so you can taper him to be off steroids eventually.
So would the IgE monitoring in any way decide the duration of steroids?
Not necessarily. If you have treated the patient satisfactorily, so when you start treating, I'll come to that, but let me address this now. When you start treating, you have a baseline that you start off with, and then you follow that as you move forward. Over time, you would kind of establish some kind of baseline, new baseline. You're probably never going to be able to go back to zero or normal limits. As long as he's doing well symptomatically and he doesn't necessarily technically meet the criteria for ABPA, then you can leave that person stable at that point and continue to monitor. Like I said, there's no defined period to continue to monitor these people for. So it's something you're going to have to wing. Okay. So you kind of follow them intermittently, just to make sure that they are still doing okay. You probably never be able to say you've cured a person of ABPA. So this is pretty much the study on which most of what we do is based. The small study was done somewhere in the 2000s, came out of Boston. So it was two-phased, double-blinded, randomized control trial. It was pretty well designed. Their target sample size initially to be adequately powered was 68, but they were only able to recruit 55. And that's just because it was so slow recruiting these patients that they decided to go ahead and analyze their data, and turned out to be viable. The first phase had double-blind itraconazole at 200 milligrams twice daily against placebo for 16 weeks. And then in the second phase, all patients were treated with itraconazole for 16 weeks, 200 milligrams twice daily as well. So apparently some people got itraconazole for a 32-week period, and some people got for the second 16 weeks. And they didn't have any patients with cystic fibrosis. They did some laboratory testing at the point of study entry, and that's 16 and 32 weeks, and chest x-rays and every 8 weeks for 32 weeks. So this was what they used as their response criteria, reduction in dose of steroid by 50% or more, and this is based off your normal asthma stepwise therapy. I've never tried to give a person more steroids than they need. And then decrease in total IgE by at least 25%, and at least one of increased exercise tolerance, improvement by 25% in their PFTs, and resolution of infiltrates present at enrollment. We have the baseline characteristics of the patients on the left, and rates of response on the right. They found that they were able to decrease the use of the corticosteroid doses, and overall response, there was a significant difference between the itraconazole group and the placebo group, which was what was expected. So using the endpoints they set, 46% of those who received itraconazole met the treatment endpoints, compared to 19% of those who received placebo. Now, one thing I should mention is that in this condition, some patients will resolve on their own anyway, regardless of what you do. Of those who didn't respond during the 16-week initial period, 1/3 of them responded in the latter half, and there were no relapses during the trial 32 weeks. That's kind of like a tricky statement, because like we talked about, some patients got itraconazole for all 32 weeks. You wouldn't necessarily expect a relapse in those patients. And the other patients got itraconazole for the second 16 weeks. So they are actively on therapy at the time. So there were a couple of problems with this study. There were no patients with cystic fibrosis, which probably make up a greater proportion of the patients who get ABPA. And there were quite a few adverse effects. So I don't imagine that compliance was very high. Greater than 80% of the study participants had adverse effects, none of which was enough to stop medications. They did not measure any itraconazole levels, which is part of the recommendations. And we did not, through the study, we're not able to determine the optimal dose or duration of therapy. One thing to mention is that because we don't know the levels, normally when you're given itraconazole, you should follow the levels over time because of genetic variations, which would affect the effective serum levels. We don't know if those who did not respond had those genetic variations or otherwise, and the dose and duration of therapy was not determined. Going back to the next, there are a couple of other studies, none as important as that one. This study was done to compare the use of medium dose steroids or high dose steroids for treatment of ABPA. And what they did was that they used 0.75 milligram per kg for 6 weeks and then tapered down, as compared to 0.5 milligram per kg for 1 to 2 weeks and then tapered down. This was a randomized control trial. So subjects who were treatment naive, newly diagnosed, never been on antifungal therapy, and hadn't received any steroids for the past 3 weeks. For more than 3 weeks in the last 6 months were enrolled. Patients who required use of antifungals at the same time were also excluded. And these were the results, and the only results that you can find that are significant are percentage decline in IgE after 6 weeks of treatment, and those who had high dose steroids were the ones who had a higher decline, which is expected. Steroids would reduce the amount of IgE and its side effects. So those who had higher doses of steroids had higher incidence of side effects as well, which you would also expect. And the outcomes of this study were that medium dose steroids are pretty much as effective as higher dose, but the higher dose led to more side effects. So at the end of the day, you only had one option to continue using the lowest possible dose that would achieve your desired outcomes. There were no cystic fibrosis patients again, and a very large number of patients were lost to follow up. So we don't know if the reason why they were lost is because they were doing much better and just kind of disappeared. But it turns out that both arms of the trial had pretty equal numbers who were lost to follow up. And there were no quality of life indicators measured in this study. Next study which was done was role of inhaled corticosteroids. Now, these studies were not done in any particular, in this presentation, they're not arranged in any particular chronological order. So here, what they did was that they took 21 patients who met diagnostic criteria for ABPA, who refused treatment with oral corticosteroids and itraconazole, and enrolled them. A lot of the reasons why they refused treatment, why they were classified as refused treatment, was basically because they couldn't afford the medications. This study was done in India. Patients were treated with a combination of formoterol and budesonide and followed at 6, 12, 18, and 24 weeks. And if IgE levels were not controlled at 6 months of therapy, they started them on oral corticosteroids. And they found that there was some improvement in patients who were treated with inhaled corticosteroids, but none had good control of their asthma, which is expected because you have continuous antigenic stimulation. Well, the most important finding was that after 6 months of therapy, the median IgE levels had risen by 99% in most of these patients. And then after that, they did have to initiate oral corticosteroids, and there was complete resolution of asthma symptoms in 19 out of 21 patients, and IgE levels fell by 52% median after 6 weeks of initiation. The median duration of follow-up was about 15 months, which is pretty long, and 18 patients achieved complete remission, which is defined as remission greater than 3 months. and 3 patients had a relapse in 15 months, which is pretty decent. So this is kind of like a plot of the IgE levels for these patients, and right about the initiation of oral steroids. Prior to the initiation of oral steroids, you had a progressive climb in the IgE levels, which of course makes sense. Like we talked about, you have persistent antigenic stimulation, and eventually, as soon as you introduce oral steroids, the levels pretty much fell. So the final conclusion was that inhaled corticosteroids by themselves have no role in the management of ABPA, but can be used as additional control of asthma. So just giving a person inhaled corticosteroids doesn't really help them for the control of ABPA. I tried to find studies where they did inhaled corticosteroids and oral antifungal therapy, and I wasn't able to find any such studies. Okay, so let's go to inhaled antifungals. You have very limited data, very few studies for some reason. The largest series that we had only 7 patients in cystic fibrosis patients, but there was quite a bit of benefit. 17 out of 19 patients had improved control. There was a lack of systemic side effects, which anybody who's ever given itraconazole realizes that it's very difficult to give it straight away for a good 6 months. It's probably almost impossible. But the logistics of inhaled antifungals might interfere with using that as a therapy to control ABPA. So this is kind of a slide compilation of all the available studies that have used inhaled amphotericin B as treatment for ABPA. And if you look at the number of patients, some of them are just 1, 3, 5, 7, but they all had positive effects with their disease at the end of the day. So there's fair data to use inhaled corticosteroids. So this is another study comparing the use of voriconazole and posaconazole, which are derivatives of itraconazole, in patients with ABPA. So what they did was they found 26 patients who had ABPA and SAPS, which is severe asthma with fungal sensitization. It's pretty much a spectrum where patients do not meet the diagnostic criteria for ABPA, but would have evidence of allergic sensitization with high IgE levels. All these patients had previously received itraconazole but had been discontinued due to adverse effects. These patients were treated with voriconazole or posaconazole for 6 months, and dosing was adjustment with serum levels in this case. The target serum levels were the same for invasive aspergillosis. If that's appropriate, we really don't know. I don't imagine that the serum levels needed to control invasive aspergillosis and the levels needed to control airway disorders are the same, but we really don't know that for a fact. And this pretty much was the results table. Most of the patients derived good treatment, 17 out of 19 like we talked about. But if you look at the adverse effects and those who had the medications discontinued, I think those are pretty good rates. 0 out of 3 were discontinued at 12 months. And same thing for posaconazole, 0 out of 9 at 12 months, which is fairly decent, considering that about 40% of patients who receive itraconazole are not able to tolerate it. In this study, there was better control of asthma in 2/3 of patients, and 30% of study patients were able to completely discontinue oral corticosteroids, and it was shown that use of voriconazole and posaconazole resulted in decrease in total IgE levels. You would expect that. It was a retrospective study, and sample size was small. You only had 26 patients. But one benefit was that this time serum levels were monitored and targeted for treatment. Then comes the next question. What do we do with the anti-IgE medications, omalizumab? So we had the study done at randomized controlled trial with 2 treatment phases of 2 months or 4 months each, with a 3-month washout period. Adult patients with poorly controlled ABPA and symptoms were recruited. All the patients were also met diagnostic criteria for ABPA, and patients who had been on antifungal therapy were excluded. Patients who were on maintenance therapy for asthma was held during the duration of the study, and patients were randomized to use of omalizumab or placebo. Now, at this point, I'll point out that the original studies for omalizumab in asthma was only for patients who had IgE levels between 30 and 700, which is kind of extremely low. Well, it's technically outside the diagnostic level for ABPA. ABPA patients are characteristically well over 1,000. The primary endpoint was number of exacerbations during the treatment or placebo phase, and exacerbation was defined was no respiratory symptoms and needed oral corticosteroids. Secondary endpoints were also monitored, and over here we have a table which kind of describes the outcomes, and it turns out that patients who received omalizumab had quite reduced exacerbations and also had decreased IgE levels as well. So the points to take away were that omalizumab is an effective therapy for ABPA with decreased rates of exacerbations in the treatment phase. Of the 13 patients they had, 10 of them had levels that were much higher than you would ordinarily use omalizumab for. It's simply not indicated. There were no studies done in those kind of levels. There is no FDA approval for this indication, so it's not currently being used. A lot of people are looking at it, but it's not currently being used. And cystic fibrosis patients were excluded. The only thing that throws a little bit of, not necessarily doubt on this study, was that there were members of the investigating body that were involved with drug companies, but none of them was involved in the drug company that made omalizumab, so I don't imagine that they have any interest in promoting that medication. In summary, ABPA is a chronic disease. It's almost impossible to get rid of altogether. If you want to keep it simple, there are 2 things to target: reduce inflammation, reduce fungal burden. However you achieve that, go for it. And that's it. Here are my references. Any questions, please? Any questions?